Hello, I'm Patrick Daly and I'm one of the team at the Rural Doctors Association of Australia. Each year, RDAA and the Australian College of Rural and Remote Medicine, or ACRRM, offer excellence awards that recognise some outstanding rural generalist doctors and some inspiring future doctors as well. Today's podcast features Dr Regina Waterhouse, one of two doctors who received the ACRRM-RDAA Rural Registrar of the Year award for 2022. Regina, or Dr Reggie as she is affectionately known by her patients, has been providing medical care on Palm Island for more than 18 months after completing her obstetrics training in Cairns. A proud Torres Strait Islander woman, Regina was born and raised in Far North Queensland. She initially trained as a teacher and worked in the community services and disability support sector before completing medical school as a mature age student. I spoke with Regina in the lead up to the Rural Medicine Australia conference in Canberra last October. Before we begin, I'd like to acknowledge the traditional owners of the land we meet on across Australia as we listen to this podcast. I'd also like to pay my respects to elders past, present and emerging, and welcome any Aboriginal and Torres Strait Islander listeners who may be joining us. Congratulations, Regina, on receiving the ACRRM-RDAA Rural Registrar of the Year award for 2022. What was your reaction when you found out?
Completely stunned and still a bit stunned. So very honoured to be acknowledged. I do think that's a big honour for me. So yeah, thank you.
Wonderful. Tell me about your childhood. Where were you raised and where do you call home?
Okay, so I was born up in North Queensland, so born in Cairns, and then grew up a little bit south of there in the town of Tully, and then later in Ingham, and went to high school there. Didn't go to uni in Queensland though, went back down to New South Wales to do that and was away for quite some time. But I came back in for internship and did that at Cairns Hospital and stayed there through my training for obstetrics for the Transcog Advance, and then have been in Palm Island ever since. So I'm between Palm Island and Townsville. My family are based in Townsville, and I kind of fly backwards and forwards and get the ferry backwards and forwards between the two. Yeah.
So tell me about your childhood. You've got a long history going back in the Torres Strait, as I understand it.
Yeah, so my family's all from, my mum is all from Badu Island. So the family were all up there up until I think the late 70s. They would have all relocated down here. So my grandfather and my uncles were all pearl divers. So very much a part of the pearling industry in the Torres Strait and on Badu Island. And when that industry kind of ended, they all needed to relocate for work for the families. So my granddad sort of packed everyone up and they all landed in Tully and were based there and spread out from there, but mostly in Tully. Yeah, and have been on the mainland ever since. We have a few relatives still up in the Straits and certainly in Badu and TI, but everybody is quite spread out these days and scattered across Australia, but primarily North Queensland. Yeah.
So coming from an island sort of background, do you think that was part of the appeal of moving to Palm Island as a doctor?
Absolutely. I do have sort of extended family links to families on the island here that are sort of cousins of my mother. So there's links there as well, but definitely the island, it's pristine when I look out the window, and certainly some of the best sunsets I've seen. So big draw card of living on an island as well. There's appeal there.
Tell me about your childhood a little bit more, and I'm particularly interested to know whether anything in your childhood got you interested in medicine or exposed you to medicine as a career. I know that you didn't come to it straight away after graduating from high school, but was there anything in your childhood that gave you an inkling that rural medicine or remote medicine might be something you should be interested in later in life?
Yeah, I guess I didn't. Well, the first Barbie I ever had was actually a Dr. Barbie, so I suppose that was a first clue. But but my mum, and what will happen often in island families is you tend to get one sibling or a person that tends to take on a lot of the care responsibilities for elders and other people in the family. And my mum was certainly that person. So she was the youngest girl out of about 9 children. And my grandfather had an acquired brain injury from a work accident, and it was certainly her role in the family to come home and look after him, which is what she did. And then later on took on caring responsibilities for my grandmother, who was diagnosed with Parkinson's disease, and then another, her auntie, who also had some mobility issues. And then later on, my father actually had a glioblastoma, so he passed away of a brain cancer, and she took on caring responsibilities for there as well. So she's always been the carer in the family from all of my life, and taken on those responsibilities, and in that has always been the one to have to take people to doctor's appointments and specialist appointments, and deal with the kind of the GPs and the hospital side of medicine. So spent a lot of time in waiting rooms, a lot of time. Clinics have always run about 2 hours over time,
Right.
and it's no less frustration when you're on the other side of that door. So I've spent a lot of time in doctors' waiting rooms, and now on the other side of the corridor. But so there's lots of exposure, I guess, to the need for healthcare, and particularly with our family, of all those comorbidities that happen with chronic disease. And my mum herself had end stage renal disease and was hemodialysis dependent for, I think, nearly 15 years that she spent on dialysis. So lots of time getting to know the specialists involved in her care, and the nursing staff. So that was very much a part of my childhood, being the patient and the patient's family. And then it's taken a bit of a divergent route to get back to actually being on the other side of that door. Yeah.
Tell me about chronic disease and how it's impacted your family, particularly over the years, over the decades. From a personal perspective, what has that meant to you and your family?
Well, I think it's you kind of go on that, and I suppose it's almost a grieving process that happens with chronic disease in particular, when it starts to take away part of a person's life, and then their mobility and their morbidity sort of issues start stacking up when they start to lose independence and all that kind of thing. So and then certainly managing the complications that come with that. And the renal disease being a prime example of that with mum. So she went from being the one taking care of everyone, and then slowly, very slowly, gradually over the years, having a bit of her independence taken away, and watching the kind of shift that happens to a person, and then the strain that sometimes puts on the family and extended family when they have to make adjustments to care for that person, as they start to lose bits of themselves because of chronic disease, and especially when you start getting those complications. She was certainly a patient that had a lot of issues with calciphylaxis, so she got a lot of chronic wounds that were very, very painful and took long times to heal, and spent a lot of time getting to know the vascular and the surgical teams as well, because they got to know her very well over her time there. So yeah, there's a lot of in and out of hospital, and a lot of dealing with, I guess it is a loss of yourself, and what you can do when you start to have that being impacted by chronic disease. Which is not only difficult for the person that's doing that, but it's difficult to watch when you're a family member as well. Yeah.
As part of that process, you've said previously you'd seen the good, the bad, and the mediocre of patient care. What did you take away from those experiences in the hospital and medical system?
I guess you're talking about a lot of it had to do with communication. I guess that happens a lot with in medicine. you can be brilliant at it, but if you don't communicate very well, the patient experience is always a negative one. And I guess a prime example of that is when you're breaking bad news, and certainly as a family member, I've been on the receiving end of bad news quite a fair bit, and especially as a Torres Strait Islander, you get a lot of bad news, and so you get to see how a lot of different people deliver it, and some do it really, really well, and some do it terribly, and I guess the difference does come to communication, and I guess a traditional model is you'll have they'll call a family meeting and everybody will sit around, and then they'll dump a whole heap of information on the person and their family, and then they walk away because they've done their job. They've delivered the bad news and they leave it at that. But the teams that have been exceptional, and they have been teams that have done it, is yes, they have had that kind of that traditional initial meeting where everybody kind of puts the cards out on the table, but they followed it up, and they followed it up with opportunities to talk, and for the family and that person to process that information and come back and ask questions. And particularly when dealing with First Nations people, that's extremely important that they have that opportunity to revisit that and to kind of explore that, because otherwise it tends to get lost in translation, and then you get people that just end up and they're non-compliant, or they've discharged against medical advice because they've not had time to process any of that information. And I guess the teams that will do it well, you'll have that after that kind of an initial consult, you might have a really switched on registrar or resident that then will talk more about it, or go out and if specific people have questions, and not just the patient, because sometimes it's not just the patient, it's the people that's around them and who their support network is. That might be the cousin brother, it could be the auntie, or it might just be that younger daughter that happens to be in Sydney at med school, and taking that time to find out who that person's support networks are, and making sure that they have the information they need to support that person through whatever their journey is. And the teams that have done it really well have made allowances for that, and have made sure that follow-up has followed through.
Do you think it's improving generally across the medical system in terms of approach to patient communication and patient care?
I think there's probably more of an awareness that it's important. So you don't have to argue with people that that's something that's needed. But in practice, it gets hard. And I guess the practicalities of that is everyone being under the pump and short-staffed, and teams being stretched to capacity. And if everyone's sort of fatigued, and particularly COVID adding to that burden, and other strains that are on the hospital as well, then you don't often have the time to do that, which is best practice. So everybody knows it's a great thing to do, but in practice, it can be really hard to deliver on that. And I don't think there's an easy answer to solving that problem, unfortunately.
Now let's look back to when you came to medicine. You came to medicine as a mature age student. Tell me about the road you took to get there, what you were involved in before deciding on becoming a doctor, and what made you decide to study medicine.
I had science teachers when I was in high school that were kind of were pushing for me to consider medicine, and did say that would be a good choice for them. JCU was a brand new medical school, so that gives away my age, and I probably shouldn't say that. So they were
not as old as me, I can tell you.
So they were saying that it would be I would be the type of student that would go and do well at JCU. But at that point, I come from an Islander family, and my mum didn't get past year 8, and even my dad, who's is Caucasian and from Melbourne, but had quite a difficult childhood as well, and didn't get past year 10. So neither of my family members had finished high school, let alone my parents gone to tertiary education. So the fact that I was even in year 12 was a bit of a miracle. And the fact that I wasn't pregnant was an extra bonus. And considering uni was a big thing as well, but going that step further and considering something like medicine was just a bit beyond me, and something I couldn't really contemplate at that age. So I did end up going to uni. I went down to Armidale in New South Wales, and Mostly because they have beautiful trees. Armidale turns
It's a lovely place.
turns red and gold in autumn, and that was a big draw card because it wasn't North Queensland.
No, that's right.
So I went down and I did teaching. Was where I started, and I did a teaching degree. As I got towards the end of my teaching degree, I got a bit restless and decided I'd go external, and did my teaching pracs externally. I did them, unfortunately, on Sydney's North Shore, which turned me completely off teaching because I didn't like that experience at all. I couldn't imagine doing being in those high schools, and I think I did go to schools that were quite privileged and with their demographic, and it did not sit very well with me at all. So
they've done you a favour in the end.
Yeah, I ended up switching to just straight science, but continued to do that part-time and external. And I while I was doing that, I was actually working in disabilities. So for a while I was working in early education and childcare centre, and then I worked in disabilities, and started off as a support worker, and then later on started doing things in the employment space. So supporting sort of case management with people finding jobs in open employment, and then sort of managing a program with transition to work with people with intellectual disabilities primarily, and supported employment. So yeah.
And this was mainly with First Nations people?
No, this is with everyone. So there's people with, I worked for the Cerebral Palsy Alliance. Well, they were the Spastic Centre then, but they changed their name to Cerebral Palsy Alliance. And that's people with cerebral palsy, a lot of them quite profound physical disabilities. So I guess a lot of the medical stuff came in then because they had a lot of high medical needs and people that were non-verbal. A lot of them had modified diets and certainly a lot of issues around that as well. And then later kind of working with the intellectual disabilities and people with autism and stuff like that. A lot of dual diagnosis there as well with the mental health in both those areas, and then with people that were a very vulnerable, I guess, sector of our community as well, that I worked to in there. So across a lot of different programs in that, and then sort of the coordinating and doing the team leading part of those programs too towards the end of it, before deciding that I was getting older, and if I was going to go back to study, I better do it soon. So
what was the trigger to medicine then?
It was always something I had in mind, and it was always something that at different stages I'd had started thinking about it in high school, but then had kind of dismissed it, and then thought about it a bit later, and then other life events happened, so it got put off for a little bit longer. And then I kind of I guess I had a boss while I was working in one of the group homes that said you need to go back and study because you're wasted. And that sort of stuck in my mind. Then later on, just doing that again when I kind of entered into roles that were kind of more middle management than anything else, and getting very, very frustrated with not able to move things at a governance level. Because of just being in really middle management's one of those awful positions where you're responsible for all the things that your staff do, but then you have no power to change it because of your bosses. You're really stuck in the middle. You're stuck with the systems that you inherit. So I got very frustrated with how things were at a systems level and the ability to be able to change that. And some of the board members happen to be doctors, so we're just like, okay, then maybe going back and addressing this issue and moving in this space might be a way that I can bring about change, which has always been something that's driven me when I see some systemic faults in the way that we do things.
So fast forward, you've completed your medical degree and you've become a GP registrar, a rural generalist registrar, now working on Palm Island. And I think you've completed your advanced training in obstetrics as well. Tell me about your day-to-day work life on Palm Island. And also I'm interested in hearing a little bit more about the challenges in delivering medical care on some of those in some of those more remote locations, including Palm Island.
Yeah, I guess yes, I did my Transcog advanced training, but didn't actually. We don't, well, not deliberately. We don't deliberately birth here on Palm Island. To say we don't birth here is inaccurate, because we do.
Yes.
Sometimes you can't you
No,
can't avoid it.
that's right.
But we don't plan to. So I haven't been able to practice my skill in that. I don't have a theatre, and I can't do Caesars, though I've been taught how to. But I certainly do work quite closely with the obstetric team at our tertiary centre, and a lot of the antenatal care, and part of the challenge with the women here in particular is that a lot of them are quite high risk, a lot of birthing complications, very difficult to engage in antenatal care, very and a lot of them that have had babies before have often had quite traumatic experiences because of care that's been been really quite culturally inappropriate, and a lot of that time that's the nature of what happens in tertiary centres when they don't when they're busy and they're under the pump, and then they don't follow through, and often the more difficult patients that have that a lot of the difficult psychosocial stuff happening around them, because there's trauma, both their own trauma and what's inherited, and all the issues that go with that. Having the time to deal with that when you're a very, very busy unit is often doesn't happen, and they're the women that fall through the cracks, and they're the women that are my patients now. So I've been able to work quite closely with one of the consultants in particular that comes out and does ultrasounds in an ultrasound clinic, and sort of takes responsibility almost for the Palm Island women that go over to Townsville in trying to engage these women and care for them appropriately during that antenatal period. And we've been doing that for 2 years now.
Has that engagement really made a difference in terms of management once your patients get to the tertiary hospital?
Yeah, I think so. I think the flow that there's someone that knows what's going on, it helps that because I think back in the day they would just go under whichever consultant happened to be on the on-call roster, which is what happens in most places. But for the last couple of years, they do try to get admitted under the same consultant. That does make a difference in that most of the time she's already met them. She's already at least seen their scans and has some idea of what the social things are around them. And I've been involved working with the midwives in her as well, so that we can sometimes sort things out in that antenatal period to try and make it all a lot smoother. So I guess if they have no antenatal care and they kind of get to Townsville, it's all a disaster, because everything is really at crisis point by the time they get there, and that and I think that is what often contributes to the trauma of everything as well. But if we're able to try and at least sort some of that beforehand, and an example of that would be we have either type 2 diabetes or gestational diabetes. We have high numbers of both on the island, and when they're in pregnant women, that obviously presents all sorts of complications. But things like stabilizing their blood sugars and trying to get them on an insulin regime that's appropriate, and providing the education around that, we have been able to coordinate that at a local level here on Palm Island with input from the obstetric medicine and maternal fetal medicine as well, so that we can kind of get their blood sugar stable, so that they don't end up with the horrendous complications at the end of it. Sometimes it doesn't work, but we do try and do that as much as we can. And try to really pick up on things as early as we can, so that we can do the interventions that are needed, and hopefully end up with a better outcome.
Tell me a little bit about those psychosocial inputs or challenges that are faced on the island there from the local community, and how you work as a local doctor to overcome those.
Yeah. So Palm Island in particular is quite in some ways quite a unique community. There are certainly communities that are similar, but not many, in that it's entirely a construct of the Queensland government. And it's a product of really racist and horrendous policy over decades, that has resulted in the community that we know now. So the traditional owners are the Manbara people, but there's refer to the people living here as Boogaman as well, which means many tribes, and it's literally what they are. There are over 40 tribes of people that make up the people that live here, from both the Torres Strait and other Aboriginal communities. So it's an eclectic bunch, with all different and all of those tribes are different nations in themselves. They're different language groups. They have their own belief systems. They have their own histories, and they've all been put on an island and told to get along. And so there's all sorts of issues that come up with that. And because of the way in which they were dispossessed from where they come from, there's a lot of trauma that's now intergenerational. That's come along with that, and then you have some horrendous health outcomes because of that. So on paper we have, I think, around 2,500, but it's hard to know exactly what the population is, and it certainly fluctuates, and it fluctuates quite a fair bit. So you have people that live for a period of time here, you have people that live in other communities, and like Townsville predominantly, but also other communities that will live there for months as well. So it can be quite difficult to track people down because they literally could be anywhere. And then you have the practical issues of nobody has a mailbox because there's no mail delivery. The post office is a shipping container with a window cut out of it, and sometimes it's open, sometimes it's not. So you may or may not get mail. So that's really hard when people send specialist letters to a post office service that's virtually non-existent. And also if that happens to be an appointment letter, and then the patient doesn't get that appointment letter, and then they get marked as a failed to attend, and then suddenly they're off the specialist list and they don't get to see the specialist, and they don't get to the care that they need. And lots of people fall through the gaps because of that. And the same with the phones. They're only Telstra works. The other the providers just don't work on the island. So very limited there. And then there are also patches within the island that don't get any reception at all. So sending people a text message for an appointment doesn't always work. Because
how do you overcome some of these barriers?
A lot of that kind of thing is working with the health workers, and I think they play quite a pivotal role in that, in the knowledge that they have, in that they tend to know where people are, and physically going out and finding people. And sometimes it is as simple as you see them on the street and you go, come see me. You need to come see me. Yes. I will be there this day. Come and see me. And they will come and find you. And that often comes with, again, stability of having staff that have been there for a while, because people get to know you. And it does take a good couple of years for people to not only know you, but then trust you.
Absolutely.
And especially when so many times in the past they've been disappointed and let down, that trust is not easily won. So a lot of the time it is just knowing what those family connections are and how to find people, and that the health workers and the locals that work within the staff are pivotal to that.
So what have been some of your highlights, I guess, of your medical career to date, but more importantly, your time on Palm Island? What have been some of the takeaways that you've thought, oh gee, I've actually made an impact here, and it's been a really special thing, not only for the patient but for me?
Yeah, I guess well, anytime I deliver a baby, that's always special, no matter where I do that. So that's always a big thing. But I think a lot of it's been about, because I'm a Torres Strait Islander doctor in an Aboriginal and Torres Strait Islander community. There is a lot to be sad about. There is a lot that makes you cry. But there's also a lot of joy in that. So even though I've had some really horrendously horrible days, I've also never laughed as loudly or as hard as I have here. And there are wins if you look for them, which is probably my big takeaway. And sometimes that's as simple as I've had women come to me for preconception counselling. That means you have a woman that is actively thinking about planning a pregnancy and having that pregnancy progress well and is engaged in care, and that's a huge thing. I've had type 2 diabetics who have recorded their fasting blood sugars and their postprandials and written them down and brought them to me to say, these are my blood sugars, what should I be giving myself an insulin? And they're actively engaged in their care, which is amazing when you see it. And it can be as simple as having a partner, so a man actually attend with his partner to an appointment and listen to the antenatal education and pay attention to what you're saying about pregnancy and birth. Which for the space that I work in is always really encouraging to see men in particular be engaged with their partners when they come in for that, for those appointments. And we've also had things in the hospital, like we see a lot of, we have a lot of high smoking rates. So you see a lot of crumbly COPD and people with poorly controlled asthma and the like. And to have a patient that used to be in resus every other week and then suddenly not see them for a couple of months, and you start wondering whether or not they've passed away or moved or something's happened, and it turns out they've just quit smoking. So they haven't come to the hospital because they haven't needed to.
No, fantastic.
Yeah. So there are certainly those wins that if you're here long enough and you're actually actively looking for them, you do see them.
You can see them,
yeah.
What about at the I guess a wider level? You're not only an ACRRM registrar, but you're also, as I understand it, on the ACRRM Council. And you've said you're working to give voice to an Aboriginal and Torres Strait Islander perspective, I guess, in rural medicine. What are the main perspectives you think need to be more strongly espoused when it comes to First Nations healthcare?
Well, I think it's probably challenging a lot of those stereotypes that we often see quite frequently in health, and I was supposed to use the jargon, you're moving to a strengths-based approach when you're looking at Aboriginal and Torres Strait Islander care instead of always looking at the deficits.
Yes, right.
So you'll often get attitudes of Aboriginal and Torres Strait Islander patients being the ones to discharge against medical advice, or to not be adherent to medications, or to not very interested in their overall health, and to just generally be hopeless cases, which in reality is not true at all. So certainly challenging those stereotypes when they exist in health has been important for myself, and I know a lot of Aboriginal and Torres Strait Islander doctors feel quite strongly about that as well.
Is that perspective changing in the medical profession, do you think, now? And is it changing fast enough?
It probably is changing, but slowly. And I think health is a little bit behind other industries, perhaps, in that respect. It's been very slow to change here, because I know it would be probably 15 years ago now, when I was working, certainly part of the disability sector, that increasing Aboriginal and Torres Strait Islander engagement and access to services and all that kind of thing was very much a focus back then, but it's probably taken another decade and a bit for it to start to filter down into services, health services, as being a priority, and something that organisations at that sort of governance level need to actually be addressing. And addressing in a meaningful way. So it's all really nice to put the artwork up, but if you don't back it up with anything of any substance, it doesn't mean much.
Yeah. Absolutely. We're running out of time, but I just did want to talk to you a little bit about breaking down gender bias in medicine. I know you're a case study in this, if you like. You have 2 young kids. You've got a husband who's taken on the role of primary carer of your kids while you work full time. Tell me about that arrangement, how it's worked, and how you communicate this concept to younger colleagues who might be facing the sort of balance and challenges in that balance as you have likely faced in terms of study, working, raising a family, all at the one time of your life.
Yeah, I think it's hard, and no matter what time you choose to have a family, it's always going to be hard.
Yes.
I don't think it's any particular golden time where you can pick and have it all work out perfectly. And it's been very much, and I talk and you get asked about your journey through medicine and all the rest of it, but it hasn't just been my journey. It's so what my husband's had to go through has been just as epic in terms of personal growth and train and having to put up with the craziness that is medicine, even though he's not medical himself. So he works in finance in a completely different industry. And doesn't have that medical background. So I do feel sorry for the people that have to put up with us when they're not in that world itself, because it's quite different to everywhere else. So he's had to go through an adjustment every step of the way with me, which has been difficult because my job is so inflexible, and with my training requirements and all the rest of it, sometimes there's not a lot of choice. He's had to be the flexible one and the one to bend, because there had to be somebody that was able to bend. And then he's had to then I guess work out his own identity. So before I started medicine, and we were certainly a couple before when I started medicine, he was very much a corporate suit and had an office on the 18th floor of Wynyard, and that was very much his life and a strong part of who he was. And so to then have to shift to rural and then later take on the responsibility for kids has been a whole new identity for him to have to rediscover.
How has he found that? How's he found that shift?
Hard. and he's gotten really passionate about unexpected things like women's superannuation,
Right.
and the fact that the people that take time out to raise kids end up with a lower super at the end of it.
Yes,
this has been something that he's become unexpectedly very passionate about, because of it's had to directly impact him now that he sees that what happens when your career get interrupted like that, because you've had to take on responsibilities for the family. So often that's a challenge that affects, well, most working women would know all about that, but as a man, he's had to experience that firsthand and been quite indignant about the inequity of it all. So yeah.
Does your husband work from home now? Can he dial in via satellite to still work in finance when he's got a chance between raising kids?
Yeah, he does. He's a finance broker, so he runs his own business from home. Yeah.
Fantastic.
He does a lot of his stuff by Zoom and is often photobombed by our kids.
Yeah. Fantastic. Back to medical mentors. Do you have a medical mentor who's stood out to you as someone who's inspired you or supported you during your medical career? Someone who really stands out as being a champion for you, or someone who's really changed your view of medicine or your view of medicine as a career?
Yeah, I've been really lucky in that there's been more than one. There hasn't just been one single person. It's been a lot of different people, and it's been I don't know whether I've found them or they've found me, but I've stumbled across them at the right time, in whatever particular stage I was at, and whether that be the first year PBL tutor that was probably one of the most patient and kindest people, GPs, that I've ever met. That was my first PBL tutor, and through to my supervisors that I have now, and even my peers. I've certainly gotten a lot of support from really excellent supervisors over the years, and being on, I guess, to do an RG plug, the RG pathway, you certainly meet a lot of really inspirational doctors that take on a mentoring role to the registrars that they do work with as well. And I've certainly been privileged enough to get to know them and been involved with ACRRM and getting to know some extraordinary people that way as well. So it hasn't been one person, it's been a collective. And I think that kind of reinforces what my PBL tutor did tell me, that medicine was a team sport, and that you don't ever do anything alone. And even when you have those weekends where you're the solo doctor, which I've certainly had those weekends where I've been the only doctor on Palm Island and it gets crazy, you still have help. And sometimes that's through the dialing into RSQ and you've got a consultant on the other side, or sometimes that's through your own personal networks where thankfully there are people who I call and they will answer their phone, which is really a nice collection of numbers to gather over the years, that if you do just need advice, or sometimes you need to debrief, or sometimes you need to talk through a case, there are people that will pick up the phone and have that chat and provide that support. And that's been really important, particularly in a rural setting where it can be really isolating to have those networks.
Looking forward 10 years, where do you see your medical career going, and what sort of practice mix do you think you'll be doing?
Oh, I have no idea. Absolutely none. I certainly enjoy obstetrics and would like to retain that skill. But there's other, and then the reason why I chosen rural generalist is because I like everything. So ultimately it'll depend on where we end up settling and what that region needs. I think one of the things that impressed on me about talking to some of the most amazing doctors that have been around for years, and the skills that they've managed to gather and how they got there, most of the time it came because there was a need. They were where they were and they needed to be something, so that's what they became, and that they needed to learn something, so they went out and they learned it. So I think that will probably be the path I take, and depending on where I am and what they need, that's probably what I'll become.
Now, you had mentioned earlier that as a young person, I guess becoming a doctor seemed like an alien concept to you. What would you tell the younger Regina now, sitting in high school, wondering what she's going to become? How would you sell to her the concept that she could become a doctor? And I guess more broadly, what's needed to change the messaging for young First Nations people in terms of giving them empowerment to consider medicine as a future career?
Well, I think every Aboriginal and Torres Strait Islander doctor that one graduates from med school and then finishes their fellowship training, I think the fact that they do that in itself does a lot for that. When I went through, you didn't have the recognizable names as to who were doctors that were First Nations, but now you actually do. There's more than one, and more than one specialty. You start to, and so if they can do it, you can do it. Is kind of the thing. If you can see people that have a similar background to you and that look like you, have the same challenges as you, and they can do medicine and they can do well and they can be amazing, then you can be as well. And I think seeing those examples and then having so many more of them come by every year does a lot for creating that pathway. And like, I can only do what I do because of the people that walked before me, and the ones that really were the trailbreakers, to be the first all the time. And the more of us that walk that path, I guess it becomes a more well-worn path, and it becomes easier, hopefully, for the others that are following behind. And certainly that mentorship that's been provided to me by other Aboriginal and Torres Strait Islander doctors, and has been really important, and something that I'm quite conscious of providing to anybody that's junior to me, so that they always know that those networks are there and that they have that support from people that have done it.
Regina, it's been wonderful speaking with you today. I could actually speak to you for another 3 hours, to be honest. It's been great covering everything from medicine to women's superannuation. And congratulations again for receiving the award, and thanks very much for speaking with me today.
No worries. Okay, thanks.
And that was Dr Regina Waterhouse, the ACRRM-RDAA Rural Registrar of the Year for 2022. I hope you've enjoyed this podcast, and I look forward to having you tune in again. Until next time, happy days.